Hello, this is Sharon O'Brien with Emory Coding Educator with the Coding Education Department. Today we're going to review Evaluation and Management Coding, or E&M services. Selecting a level of E&M service. You review the level of E&M service descriptors and examples in the selected category or subcategory, including history, examination, and medical decision making. In order to select the right code, you must determine the extent of the history obtained, the extent of the examination performed, and the complexity of the medical decision making. The basis of all documentation is medical necessity. That and only that which is necessary to treat the patient's presenting problem should be done, and the documentation should reflect the service provided. The main driving factor in medical necessity is the patient's condition. In order to determine the extent of the history obtained, you need to look at what was documented by the provider. A problem-focused history is the chief complaint and brief history of the present illness. An expanded problem-focused history is the chief complaint, brief history of present illness, and problem pertinent system reviewed for what the patient is seeing the provider for that day. A detailed history is a chief complaint, extended history of present illness, a system review extended to include a limited number of additional systems and pertinent past family and/or social history directly related to the patient's current problem. A comprehensive history is the chief complaint, extended history of present illness, system review of all body systems, complete past family and/or social history. History. The past history could be prior major illnesses and injuries, operations, hospitalizations, current medications, allergies, which could be drug, food, or environmental, age-appropriate immunization status, and age-appropriate feeding or dietary status. The patient's social history could include their marital status and/or living arrangements, current employment, occupational history, use of drugs, alcohol, and tobacco, level of education, sexual history, or other relevant social factors. The last segment of the history is the review of systems. That's an inventory of the body obtained through questions seeking to identify signs and/or symptoms the patient is or has experienced. The body systems include the constitutional system, which may be fever, weight loss, usually reflected by a recording of the patient's vital statistics. Eyes, ears, nose, mouth, and throat, cardiovascular, respiratory, gastrointestinal, genital urinary, musculoskeletal, integumentary, which includes the skin and/or breast, neurological, hematologic, lymphatic, and the allergic immunologic system. In order to determine the examination performed, again, you may have the problem-focused, which is a limited examination of the affected body area or organ system. Expanded problem-focused, which is a limited examination of the affected body area or organ system and other symptomatic or related organ system or systems. Detailed, which is an extended examination of the affected body areas and other symptomatic or related organ system or systems. And comprehensive, which is a general multi-system examination for the 95 guidelines or complete examination of a single organ system for the 97 guidelines. Determining the complexity of medical decision making is determined by complexity of establishing a diagnosis and/or selecting a management option, the number of diagnosis and/or the number of management options that must be considered, the amount and/or complexity of medical records, diagnostic tests, and/or other information that must be obtained, reviewed, and analyzed, the risk of significant complications, morbidity, and/or mortality, as well as comorbidities associated with the patient's presenting problem or problems, the diagnostic procedure or procedures, and/or the possible management options. The physician documentation. That's where it all starts, and that's how you determine what has been documented and what should be coded. The providers normally will call this their SOAP note, which stands for subjective, objective, assessment, and plan. The subjective part is the history. That includes the chief complaint, history of present illness, the review of systems, and the past medical, family, and/or social history. The chief complaint is a concise statement of the reason for the encounter, usually stated in the patient's word. The chief complaint should be clear for each note. Each note should be able to stand alone to support that date's billing. The history of present illness, or the HPI, is a chronological description of the development of the patient's presenting illness or problem from the first sign or symptom or previous encounter to the present. It includes the following elements: location, or where in the body is the problem located; the severity, how does it feel, what's the degree of the problem; timing, when does the problem happen, or is it constant, does it happen at certain times of the day; quality, what does it feel like, or are there any other descriptions of the actual problem itself; duration, how long has it been going on; associated signs and symptoms, are there any other manifestations of the problem; context, when does it happen? Does it happen at work? Does it happen when they're walking? Or what's going on around them? Modifying factors, is there any improving from any type of treatment, or does it worsen from anything that they're doing? Review of systems, also called the ROS, an inventory of body systems obtained through a series of questions seeking to identify signs and/or symptoms that the patient may be experienced or has experienced. The following systems are recognized: constitutional, cardiovascular, genital urinary, neurological, hematologic, lymphatic, eyes, respiratory, musculoskeletal, psychiatric, allergic, immunologic, ears, nose, and mouth, gastrointestinal, integumentary, and endocrine. For a complete review of systems, all positive or pertinent negative responses may be documented, and then the phrase 10, or they may say more than 10, systems were reviewed and are negative. It allows credit for a complete review of systems. Past family and social history. Past medical history, again, are any of the patient's medications, allergies, chronic illnesses, prior injuries, hospitalizations, illnesses, surgeries, immunizations, if appropriate. The family history should be first relative removed, so that's a parent, a sibling, or their child, and very young children. It may include grandparents, parents, sibling, etc., specific diseases related to the patient's chief complaint, or a condition that could be considered hereditary or congenital. Social history, marital status, family structure, employment, sexual history, use of drugs, alcohol, tobacco, education, and hobbies. The objective part is the examination. Depending on the level that you're coding, that could be defined only by organ systems, or it could also include body areas. The organ systems are constitutional, eyes, ears, nose, mouth, and throat, cardiovascular, respiratory, gastrointestinal, genital urinary, musculoskeletal, integumentary, neurologic, psychiatric, and hematologic, lymphatic, and immunologic. The body areas include the head, including the face, the neck, the chest, including the breast and axillae, the abdomen, genitalia, groin, and buttocks, the back, including the spine, and each extremity. The assessment and plan is basically your medical decision making, and of course the plan for treatment. The medical decision making includes a number of diagnosis or management options. A self-limited or minor problem is basically worth 1 point. There should never be more than 2 of these considered in your total amount of points for your medical decision making. Established problems, which are stable, are also worth 1 point. Established problems that are worsening, failing to change as expected, or inadequately controlled are worth 2 points. New problems with no workup plan are worth 3 points, and new problems with a workup plan are worth 4 points. And 4 points is the maximum that they need to reach to be at the highest comprehensive level for medical decision making in number of diagnosis or management options. The amount of complexity in data reviewed, again, the maximum that they need to reach is a level of 4 points. Clinical lab tests, which are ordered or reviewed, are worth 1 point. Radiological tests, which are ordered or reviewed, are worth 1 point. Medical tests ordered or reviewed are worth 1 point. Discussion of test results with a performing or interpreting physician are worth 1 point. Decision to obtain old records and or obtain history from someone other than the patient is worth 1 point. Review and summarization of old records and or obtaining history from someone other than the patient and or discussion of the case with another healthcare provider that also cares for that patient is worth 2 points. Personal visualization of images, tracing, or specimens itself not simply the review of the report or 2 points, but they need to state clearly in their documentation that they have reviewed the slides or the films. The risk is maybe minimal, low, moderate, or high, and it's based upon the presenting problems, diagnostic procedures ordered or performed, and management options. And this slide is a table of risk, which you probably are familiar with, but it's pretty explicit, and you may want to make a copy of that for yourself or call and order a copy. Billing based on time may preempt the standard documentation requirements, but also has specific documentation requirements. Critical care billing based on amount of time spent caring for a critically ill patient, and both must be clearly stated within the documentation. They must state the amount of time that they spent and that the patient is critically ill. High-level inpatient discharge versus a low-level inpatient discharge is based solely on discharge taking more than 30 minutes and the time being documented in the progress notes or discharge summary for that date of service. Prolonged care, when services require much more than the usual amount of time expected and the time and services are documented well in the progress notes. And counseling or coordination of care, when the care of a patient or coordination of the patient's care takes significantly more time than normally required by a patient of roughly the same health status and time in counseling is clearly documented. That's our discussion for today. Thank you.